this thing.
No, sir,
Anyhow.
there was no trouble at all. What I wanted you in this session, and that's all matter.
Thank you.
So,
Thank you.
sir, I would like to invite the Dean, sir, for his opening remarks, please.
Thank you, Dr. Purnima. Respected Dr. N.K. Sood, sir, all the participants, all the faculties of COVAS and faculties of especially pathology, veterinary pathology COVAS, who has organized this training program. So I welcome you all, especially Dr. N.K. Sood, sir, who is my mentor actually. During my whole career at Gadwasu and still his mentor. And we all, COVAS faculty and Basu, is privileged that he is joining us very soon as adjunct professor. And certainly whatever knowledge, plethora of knowledge Dr. Sood is having in this clinical pathology, I have observed personally how eagerly and how sincerely he has established lab both at Ludhiana as well as the second veterinary college at Rampura. Sir has fully established both the labs, clinical pathology lab and pathology lab in both the colleges, and that is state of art, I can say. Whatever parameter not available in medical college, that can be done in that labs. And even I have many times heard that from AIMS sample was coming from that DMCH, Dayanand Medical College samples are coming for many diagnostic tests. So such a person who is going to deliver and enlighten us in the clinical pathology in his relevant topic, I am very much privileged from Basu family as well as from COVAS family. Sir, I welcome you and I again thank you that you have given your precious time for encouraging us and to improving our knowledge, not only for COVAS faculty but whole the participants from whole India who is joining this session. So thank you very much and welcome once again. Thank you.
Yeah, I thank you, Dr. Chandrahas, my friend and a wonderful person. We have been together, we worked together on many issues, and apart from that, we had a personal level interaction also. So I have a great regard for Dr. Chandrahas. I hope under his guidance, everything in this college will go wonderful way. He's a very, very collaborative and cooperative and positive person. So I thank a lot, Dr. Chandrahas, for inviting me. So let's start with the technical session now.
Just 1 minute, sir. I would like to introduce you. So I may invite Sanjeev, sir.
Brief, only brief.
Yeah, it will be brief, sir. I may invite Dr. Sanjeev, sir, for a formal introduction of Dr. Sood, sir, please.
Thank you, Dr. Purnima. Welcome, Sood, sir. Scientist Emeritus, पैथोलॉजी के दिग्गज हैं सर, आप पितामह हैं, हम हमारे गार्जियन की तरह हैं. And no words of praise is enough for you, sir. And all praise will fall short for you, sir. And your appreciation is beyond words. So, Dr. N.K. Sood, sir, is currently adjunct professor teaching veterinary complex Gadwasu, and at the same time, he has been appointed as adjunct professor at our university, Patna, that is Bihar Animal Sciences University. He has a long experience with working with the veterinary diagnostic services and teaching veterinary pathology with a specialization in clinical pathology, hematology, urine analysis, diagnostic cytology, histopathology, modern diagnostics, oncology, and comparative pathology. He has done extensive research work covering major fields of veterinary medicine, especially in diagnostic pathology and animal cancers. He has guided 11 MBSc students and 3 PhD students as major advisor and more than 200 students as co-guide. At FAR, he has published more than 600 articles, including 282 peer-reviewed research manuscripts, 7 review articles, 73 full-length technical papers, 230 research notes, 5 chapters in book, 1 video, and 6 popular articles, gaining more than 1,800 citations, in high index journal. He has also worked as PI and co-PI in 13 mural or extramural research projects, and he is life member of 12 professional societies. Excellent research gate standing with research interest ranking of above 93% of global scientific community of over 20 million members. He is instrumental in creation of best laboratory and teaching facility in veterinary pathology and in clinical diagnostics at the university level. He has attended 60 national and international scientific conferences, seminars, symposia, workshops, and presented more than 80 lead or invited papers or keynotes covering a range of topics in clinical and diagnostic pathology. To his credit, he is also organizing 16th Annual Conference of Indian Association of Veterinary Pathologists, ICR-sponsored winter schools, FAO-sponsored international training course for Nepalese technicians, international descriptive pathology course at Hyderabad, second Indo-Global Summit and Expo on Veterinary and Animal Sciences by OMICS, and several cultural youth festivals at the university. He has also delivered several radio and TV talks, worked as member of several expert and examination committees, University Accreditation Committee and VCI and college inspection teams, and was academic council member of Gadwasu. He has won more than 70 national and international awards, honors, recognitions, including incentives for outstanding teaching in 1993, ICR Best Teacher Award 2017, and many presentation and thesis awards, honors, as well as international and national recognitions. Cultivating aesthetic taste and associated with organization of cultural activities as president, drama, dance and music club of Gadwasu for 7 years, and organized 6 youth festivals besides other events. Under his leadership, Gadwasu team won the overall championship trophy at the Agri Unifest at Dantewada, Gujarat, in which 62 universities from all over India participated. He has also delivered 28 webinars, expert talks in last 3 years only. He has also administrative experience of more than 13 years, including about 5 years in Gadwasu and additionally 2 years in Rampura Full Veterinary College as HOD, and importantly heading the centralized clinical diagnostic lab at Gadwasu for more than 7 years. So no more feather is left in his crown, and I would like to invite sir for his deliberation, please.
Thank you, Dr. Sanjeev, for saying so much about me. I told you to cut it short, but you read everything out.
It was very short, sir.
Actually, Dr. Sanjeev also has a personal relation with me. So we interacted not only in Patna, but otherwise online several times. And he has been in continuous touch with me. So thank you very much. And I also, at the same time, welcome the other faculty members from Department of Veterinary Pathology who have joined, the faculty members from clinical disciplines and basic disciplines, as well as the students. As I was told that there are MVSC and PhD students. So I would be making it not too long today. Normally my lectures are very long, but because of sore throat, so I will be taking about 1 hour, 15 minutes, I hope so. It may go longer, depends upon. So with that background, why I chose this topic, because cytology has been close to my heart. Dr. Chandras also knows that cytology was zero at Gadwasu in 2005-06. So slowly we built up, and now we have 15 samples almost a day, maybe more, sometimes 20 samples. And still I'm continuing my services, and they overload me. And it is not finished by, my duty is up to 1 o'clock. So I take generally sometimes up to 2:30, 3 o'clock, I'm sitting there because there's so much load. So that's why I've chosen this topic. Thank you very much. So now I should share the screen, I hope.
Yes, sir.
Yes, sir. Yes, sir. Please share the screen.
Yeah. Can you see the screen or not? No.
Not yet, sir.
Have you make the host, Dr. Sood?
Yes, sir.
I
You can make it. But I have
Yeah,
permitted from my side, sir.
you have to
You can
make
share
it. Yeah.
now. Sir, can you see the green portion, the screen share screen in the bottom?
In the
Bottom fifth
bottom.
icon, sir. Bottom fifth icon from left.
Share
Just
screen.
share a screen and share a screen, but just by the side of chat or summary in between.
Oh,
Green
let me
color.
see. It is having too many things now. It's crowded.
Okay. So first you need to just open your PPT, which is you're going to present, and keep it in the background, and then share the screen.
Okay. I'll do.
Sir, if it is crowded, close the session. That means you can join again after closing all the windows.
Yeah, because it is now very crowded.
Okay.
Anyhow,
So you
okay,
can,
let me
leave the meeting
just
first and then
no
close
no no
everything.
no I'll try. I'll try.
Okay, okay.
Join Zoom. Yeah, I think I'll be able to do now. Yeah. Is it okay? Can you see?
No, sir.
So I have opened the presentation.
Yes, if you open the presentation, then you need to again enter in the Zoom. Are you inside the Zoom meeting, sir? In the window of Zoom is opened?
Actually, my son's laptop is there. It is too crowded. I have no idea about.
Okay, can you call him, sir?
Yeah, I'll have to call him.
Yeah. Everyone, we'll start very soon. Please wait for a minute or maybe 5 minutes.
Dr. Purnima, you
Sir?
ask sir to mail you the PPT. You may ask Sud sir to mail the PPT to you so that you can share on his behalf.
Okay, let's try. Let him
No,
to.
I'll do. Just wait. Kushal will do. Hmm. Share screen.
First, you can open PPT and keep it in the background and then share the screen. This is how you can select directly PPT.
It's better to ask for PPT on mail.
Yes, sir. I'll call.
Now it is done. I think it is done.
Yes, your screen is visible, sir. Now please open the PPT. Yes, we can see. Yes. Start the slideshow.
On bottom side there is one icon.
Yeah, I know that. वो नहीं, डॉक्टर साहब वो प्रॉब्लम नहीं, थोड़ा सा ना देखना पड़ता है. Anyhow, now,
Yes.
yeah.
Yes, sir. It is perfectly visible.
Yeah. So am I audible to everyone?
Yes, sir. You are audible. Please
Sir.
start.
Yeah. So, as I told you, I was going to talk about the basics of diagnostic psychology, particularly in special reference to cancer. And this topic has been so close to me, to my heart, that whenever they ask me for reference of a topic, then I choose this topic. And as you know, we have to define the cytology first of all. When cytology is, all about cells, when you talk anything about the cells, which is a fundamental unit of life, and particularly when you utilize that for the diagnostic purposes, we call it as diagnostic cytology. So this all has to be done with the help of a microscope because we cannot see the cells without the microscope. So looking at this slide, this slide has been made with a specific reference. You know that we have the different spheres, the biosphere where we are all living. And we start from atom, molecule, cell, organelle, cell, and then cells make up the tissue organ and different organs and full organisms, which includes all animal species. And same way, this is the system. So the fundamental unit is the cell. So right from the time of Virchow, who said that cell is a fundamental unit and the disease occurs at the cell level, that's where probably the cytology had its base. Later on, two people, I would name only two. Actually, there are many. Dr. Papni Clau and Dr. There was another one, okay. They had a great contribution in producing the cytology to the level we have today. So if you look the difference between cytology and histopathology, see, cytology is the cells only, whereas histopathology is cells oriented in a particular architecture. So we have a stroma and we have the cells. The stroma helps in building the architecture. So lung has a different architecture. Liver has a different architecture. Pancreas has different. Muscle has different. All organs have a different architecture. that is done by stroma. So what is missing in cytology is the stroma. So we are getting cells. So that's why it is more difficult to interpret cytology than histopathology. So for example, here, this is the cytology, this is the histopathology. So you can see this is a cancer. This is a adenocarcinoma. So here, there is no spatial context on this side. There is a spatial context on this side. You can see how the units are built here. There is not that. It's only groups of cells. So it has a potential subjectivity, heterogeneity, non-uniformity, and narrow range of materials. Because in a tissue section, what we are doing, we are taking, say, about 0.5 centimeter or 1 centimeter of tissue. Okay. Whereas in cytology, we are just poking in a 22, 23 gauge needle and getting just tip of the iceberg. So cytology has a narrow range of examination as compared to histology. If you look the differences between cytology and histopathology, certain things can be easily identified by cytology. For example, round cell tumors can be diagnosed up to 100% by cytology. See, most of the tumors, round cell tumors, the accuracy worldwide is somewhere between 98 to 100%. That's great. Lymph nodes, cytology has a great value. And nowadays, hardly anybody does a biopsy on the lymph node. People prefer cytology. Similarly, for round cell tumors, the people prefer cytology. For bone marrow also, cytology is much better than histology because we need to examine different lineages, maturation patterns of cells, which we can see only on cytology, not exactly on histopathology. Similarly, for fluid examination, fluid cytology, histology will never be good for fluids. So cytology is definitely very helpful. Detecting certain infectious agents, particularly bacteria, fungi, protozoa, parasites, cytology is very useful. Vaginal cytology, has made inroads all over the world. And a simple test, the PAP test, has helped in reduction of cases of cervical cancer by about 80% in the Western or the European world. You can use ultrasonography as a guidance for internal organs and take the cytology. Histopathology otherwise is a gold standard, and histochemistry or immunohistochemistry can be easily employed into it. Whereas immunocytology can also be done. I'll show you some pics. Then architecture is the advantage in histopathology. And if you want to see the invasion, possibly you can only presume invasion on cytology, but you can actually see the invasion of the basement membrane or the connective tissue or the adjoining tissues clearly on histology. So therefore, for grading, always histology remains the key, although for most of the things now, the grading criteria in cytology are also available. So if you look at the utilization of cytopathology, it can be done for definitive diagnosis as a screening tool. You cannot take histopathology every time you want. So you can use it as a screening tool. So you can repeatedly take the cytology after treatment or after other maneuvers for example, surgery, if there is a reoccurrence, so you can do a repeat test. Similarly, for lymph nodes, whether they are progressing or regressing, you can do a screening tool or test on them through cytology. It is also a very good way of determining the prognosis of cancers or for a follow-up of certain diseases, because you can do it repetitively. If you look at the advantages, it's very, very simple. You can come up with a cytology. Any layman who knows how to inject, how to do an injection, can do cytology. It's such a simple thing. Just a little bit of experience is must. Then speed with which you can do it in seconds. Doesn't require, it's not a long process. It's very safe. It is very safe for the patient. It's very comfortable for the person who is doing. It's cost effective, costs really nothing, virtually nothing, very few rupees, and has a potential accuracy of somewhere between 60 to 100 for different things. I told you those 100 range areas already. If there are some advantages, there are also disadvantages. I told you that earlier. So you have just a very small sample size because you are poking in the sea and picking up just a drop of the ocean, and you may not get a representative sample. There is no architecture in cytology, as I told you, and it is certainly experiential. That is very important. So there are different cytology collection methods. Some people ask me why I'm spending so much time on these. This is very, very important because many people don't know how to do all this. And if I get 10 cytology smears in our lab, 4 to 6 of them are useless. Why? Because people are not trained in taking the samples. This generally they depend upon the students, MVSC fresh MVSC students who do not know, because surgeon would always prefer to do the surgery. He doesn't want to do the cytology. He will just, entrust this work or depute this work to a student. And student, what they'll do, they will pick up something wrong. That is why we must be conversant with the different type of cytology collection techniques. So imprint or impression smear is almost the same thing. So these are taken when there is an exposed lesion or some pus is coming out or some discharge is coming out. Only then you can make an imprint or impression. The imprint or impression can also be done on excisional and incisional biopsies or even at histopathology prior to putting the tissues in the formalin. So there are several, smears. Why we make several? We make several smears because in the first one, there may be contamination. So when we want to take the tissue, for example, this is a biopsy sample. So first of all, cut it to make a fresh area exposed. And then just press it onto the slide. The first point may be thicker and a lot of contamination. As I go progressive 4 or 5 smears, this smear may be more useful than this one because this one may have too much blood or fluid of the tissue. Similarly, the scraping is another method which can be done. So scraping can be done for skin. It can be done in the conjunctiva. It can be done in very hard masses. Supposing you have a very hard tissue, then, then on biopsy, you have that tissue, you can scrape that tissue. For example, leiomyoma or rhabdomyoma, because they are very hard. So it's very difficult. So scraping may be useful, particularly for, we know that in parasitology, they use this word very often. But in pathology, this can be, apart from that, from conjunctiva or for determining the fungal infections. Swabs, where you cannot approach directly, where the lesion is unapproachable. So what you need? You need a swab. For example, into the vagina, if you want to go deep, you need a swab. If you want to go into the ear canal, you need a swab. If you want to go a sinus or a fistula, you want to go deep into the oral cavity, you want to go deep into the nasal cavity, you want to go into the rectum, so you need a swab. So generally, you can moisten this swab as a cotton tip. So you can moisten it with 1 to 2 drops of saline. Sterile, use a sterile saline. Otherwise, an old saline may have a lot of bacterial and fungal contamination, which may be giving you a pseudo thing. And then gently roll the, important thing is roll the swab onto the slide. Never be harsh. Otherwise, it's going to spoil your cells. Remember, cells are living, they are tender, they are fragile. Handle them with care. That's the key. So these are some of the different techniques. For example, here, the cotton swab, and you can see it has to be rolled. It has to be gently rolled like this. Another purpose of rolling is that supposing you have on this end of the swab something, and on the other end, the medial side, the lateral side, the upper side, the lower side may have different composition. So when you roll it, you get all the kind of cells. Another way of making is needle spread. You can make a needle spread. So it can be simply like this, or you can make it. This may be useful, particularly in certain situations. For example, the centrifuge samples from the fluids. You can make a needle spread, or some cystic cavity. You can make a cystic fluid. You can make a needle spread. So generally in our lab, we do that. Then another technique, which is the most used technique in cytology, has changed names, swapped names over time. So first of all, it was known as fine needle biopsy. Then it became fine needle aspiration cytology. Then it became fine needle aspiration cytology biopsy. And again, it became fine needle aspiration cytology. So there has been a lot of changes in the names. Doesn't matter. Some people said that it is equal to biopsy. That's why they said, now again, they have come back to FNAC. So this is one of the most commonly used technique for masses or proliferative lesions or growths. Contrary to the normal belief, most people would believe that 18 gauge needle will be very good for cytology, which is wrong. So generally, a narrower needle of about 22 to 25 gauge is better. It depends upon. For example, if you feel the cystic fluid is there or very low level fluid is there, I mean, it's a very soft thing. Then you choose a needle which is 24 or 25, because we don't want contamination with fluid. We want cells. Supposing it is a hard mass, then you choose a needle of 22 gauge, but never go to 18 or 16 gauge. The syringe can be different. So, for example, if it is a soft mass or a fluid or a blood-like thing, then a 5 ml syringe negative pressure is enough. But supposing it's a hard mass, then you need 20 ml syringe because you need to build more negative pressure. So this works on the principle of negative pressure. So what we do here, we insert the needle. First of all, we have to sterilize the area just as injection site. Just with the spirit, you sterilize it. And from the sterilized area, you insert the needle. Don't take any air into the syringe because we have to build the negative pressure. Okay. And then, poke the needle like this and simultaneously you go on building the negative pressure and pull it out. Never rub it on the surface too much. Otherwise, you will pick up the cells from the surface, bacteria from the surface. Some devices are also available. For example, here, to make it easy. Preparing the slide. The next step, once you have material onto the syringe, the best material is which is not visible in the syringe. It is within the needle or within the hub of the needle. So just transfer it to the slide, and then once you have transferred that, then you make the smears. Okay, this is methods of transfer. I have already told you. This is just different ways. So you can make a blood type smear. Simple. For example, if the material, for example, bone marrow aspirates, they are nearly similar to blood or little more concentrated than blood, you may have to dilute them. There can be a line concentration technique for very light fluids. For example, cystic fluids. You can make a squash. Squash smear is a preferred smear in cytology for most of the semi-solid materials. You can do a needle spread, as I have already shown you. So this is just summing up. So you can have different impressions or imprints. You can have a squash smear. You can have a blood smear. You can have a line concentration. This is how you make squash. So in squash, you transfer the material onto the recipient slide. Never spray it from a distance. People do that wrongly, They keep the needle at a distance and then apply the pressure. And what happens? There is a spray all over the slide. And these cells are spoiled because of the pressure. They strike against the slide under pressure, under a force. So then the cells just split up. They just break up. That's why that's not good. So just transfer it. Keep the needle close to the slide, as close as possible. Transfer it as one drop and then make a squash. You have to place over your recipient slide, the donor slide, over your donor slide, the recipient slide, and like this, and move it like this. Never apply any pressure. Don't triturate. If you triturate, that's a very big problem. Particularly in lymph node smears, I see that problem very often. You find all cells streaming. They look like threads. Many people will think it's fibrin. No. The line concentration, a word here. When you have the cystic fluids, then you want to concentrate, or when you have some trips, for example, or you have dirophilaria or stephanofilaria, microfilary, or certain heavier things, then the line concentration technique is very helpful. in this hygromas, for example, or something like mucocele, this may be also useful. So if we were to collect these samples from the fluids, for example, there can be body fluids, there can be cyst, there can be joint fluid, there can be cerebrospinal fluid, there can be urine, or there can be different type of washes. We have a tracheobronchial wash, we have a gastric lavage, we have a bronchoalveolar lavage, all different ways of doing it. And always use EDTA. Because we never know how much fibrin is there. So it's preferable to use a vial with EDTA. And remember, if something is clotting, that means it has fibrin in it. For example, if a peritoneal fluid or any other fluid is contaminated, is having fibrin, so it will clot very quickly. But if there is a lot of blood contamination, again, it is going to clot. That's why EDTA is better. So from the fluids, the slide should be made immediately. If the fluid is too thin, you need a centrifugation. If the fluid is too thick, you need dilution. It's all logical. Whatever you want to do, you should do that logically. Don't go after any, it's nothing written in the book that you have to do this and not to do this. So in the urine, they say that immediate processing is needed. If you delay it too much, then you will cause damage to the cells, because urine environment is different than the tissue environment from where the cells have come. Looking at the stains, most of the times people will ask me, sir, aapko slide bhejna kya karna chahiye? The simple thing is, send the smears air dried, don't fix them at all. And the whole process of retrieving the cells from the mass, making the smear, should take less than 30 seconds. Don't delay, don't depute. For example, a senior will say, the assistant professor will tell the PhD student, and the PhD student will tell the intern, you make the smear. So PhD student will draw the sample, keep the syringe and make the smears. That much delay is useless. It spoils the sample. So Romanowski stains are normally used. What are Romanowski stains? So you have Giemsa, you have Leishman, you have Wright stain, different parts of the word, different stains are used. And as you know that in India, people are lazy, so they prefer Giemsa stain. So instead of 20 minutes, usually in the summertime, if you give 30 minutes, it doesn't matter. But in Leishman time staining, you have to be a little more specific. For Wright stain, the results are better than Leishman. But if you make a combination of Wright with Giemsa or Leishman with Giemsa, the combination stains are always better. Why? Because you have advantages of two. So it's just a complementary effect. Similarly, if you want to show the granules of the cells, then May-Grunwald Ginza is a perfect stain. Similarly, if you don't have anything at all, then you can go for bichrome stains or etching. Then there are trichrome stains, which became very popular. The Papniclau, I told you. Okay, so this Papniclau stain problem is that you have to wet fix the tissue. The tissue has to be, the slide has to be fixed when it is wet. And how much time it takes to dry up a cytologic smear, everybody knows, just a few seconds, particularly in summer. So you have to wet fix the in ethanol. Cyano's triple stain is a little modification of, and it is a combination of three stains, Papniclau and Cyano's triple, and that takes a long time. That's why these stains are generally not preferred under only specific situations when you want to see better nuclear details, then the Papniclau stain is better. But remember, those who have seen the slides under Leishman or Ginza or Wright stain, the Papniclau looks different. So if you are not conversant, whatever stain you are doing in a particular lab, you should continue with that because you are conversant. Every stain will make the nuclei and cells look little different. Their sizes, their shapes will also be little different. So try not something new. Whatever you are doing, you should continue. Then there is a people will say there is a stain diff quick or dip. So what is that? You have in all these stains, what you have the you have the eosin and the methylene blue. Okay, in all the Romanowski stains. So you keep both the bottles differently. In one bottle you have eosin, another you have the methylene blue. First one you have the methanol, and like that. So then you have, so it's very simple. Just put 1 minute in the first, few dips in the eosin, few dips in the methylene blue. That's difficult. You can also use several ancillary techniques in cytology. For example, you can do immunocytochemistry, like immunohistochemistry, but it's not easy, I tell you. It's much more difficult than immunohistochemistry. You can make cell blocks. I'll show you one or two pictures. You can do flow cytometry, particularly for determination of the cancers or certain lineages of cells, particularly lymphomas, discrimination of lymphomas. You can do cytogenetic analysis. You can do other tests, molecular pathology, PCR, and all that. You can even do electron microscopy on cytology samples. So general approach to the cytology interpretation is whether the lesion, if there is a growth, if there is a mass, which is palpable, which is visible, either through the naked eye or through techniques like ultrasound, like the MRI, like the CT scan. So then you need to see what it is. The interest is whether it is a cancer or not a cancer. That's the first question. If it is not a cancer, then is it inflammatory or non-inflammatory? So if it is an inflammatory lesion and neutrophils are dominant, they are about 90% or more, then it is known as neutrophilic or suppurative or purulent inflammation. Generally, it is caused by bacteria, but extensive necrosis or immune-mediated inflammations may also induce neutrophilia. So it should be Generally, more than 85% neutrophils. Eosinophils, if they are more than 20% in the cytologic sample, it may be parasitic, it may be immune mediated, it may be allergic, or it may be fungal. Pyogranulomatous is another word that we use. So in this, we have at least 15% macrophages. So I said that 85 plus 15. So if the macrophages are 15 to 50% in the exudate, then we call it as pyogranulomatous inflammation. Sometimes we call it as chronic active inflammation. The difference, pyogranulomatous, when we have the giant cells. When we don't have giant cells, we prefer to call it as chronic active. So this can be in fungals, foreign bodies, certain parasites. Then there is a granulomatous inflammation when the macrophages dominate, more than 50% of the cells are macrophages. So this can be fungal, foreign bodies, or chronic. And along with the macrophages, always there are some lymphoid cells. They can be part of any of these inflammatory processes. There can be some plasma cells, there can be fibroblasts. So you need to interpret them, particularly in the light of immune-mediated reactions or chronicity in terms of chronicity. So now I go over to the cancer. I'm not going to discuss much about the non-neoplastic conditions because it's a whole lot of discussion. Probably I can go about 2-3 hours on that issue. So much material on that. So I will not go into that. Today's lecture, I'm keeping a little brief, I told you. As you can see, I'm not that well. So why there is a cytomorphic evaluation of cancer? As you know, cell is a fundamental unit, and there are two types of basically cells, the epithelial and the mesenchymal. And all animals start as epithelial, then become mesenchymal. And then there are different germ layers, and majority of the cancers are epithelial. Why? That's the question. So answer is here. If you look at the repair and regeneration mechanisms, there are three types of cells, the labile cells, which continuously proliferate. So all epithelia continuously proliferate, and hematopoietic or lymphoid tissues continuously proliferate. Then there are stable lineages of cells which have the capacity to proliferate, but replicate on demand. For example, glandular cells, mesenchymal cells, etc., liver cells. Then there are permanent cells which have hardly any replicative potential. For example, neurons, skeletal muscles, cardiac muscles, but still they can be, nowadays it is known that they can be made to proliferate under certain very specific environments or situations. So if you look at the normal growth pattern in the body in an adult individual, once you have passed that puberty stage, I'm not talking about embryonal phases or the fetal or the growing phases till adulthood, because by then cells are being added, and they're changing also. But here, what will happen? The cells are in a sort of control or cruise control. The number of cells that are dying is equal to the number of cells that are being produced. So turnover rate is equal to the death rate. So no net growth is there in an adult individual. except for addition of the adipose tissue. And that's a big problem of today's world. Opacity is the biggest, curse of this modern society, and how many diseases obesity is producing. That's another day for discussion. So if this cruise control is lost, for example, here, some cells started behaving differently. Then if you look, they are very nicely placed. So this is going to create a mass within the mass, within the normal tissue, something abnormal. Because addition of cells needs space. And that space occupying lesion is being produced, which is appearing as a mass, as a growth, or a cancer. So normally what happens, the number of cells that are being produced is equal to the number of cells that is dying. So net result is the number of cells in epithelia or in the hematopoietic tissue is same or nearly same. But can you believe if there is even 1 or 2% addition of cells, if it is 52% versus 48, means the death, the cells that are dying, that is 42%, and cells that are being produced is 51 or 52%. It may become a lymphoma. Slow-growing lymphoma is a classical example of that, where apoptosis is hindered. So in the cancer, to simplify, this is what is shown here. So cancer cells, they continuously go on proliferating. There is apoptosis, but apoptosis is much lesser as compared to normal cells, as compared to normal growth patterns. So, for example, we have a normal cell. What will happen in cancer? Why I'm showing this slide, people will ask me, yes, I'm showing this intentionally because that makes my further pathway easy, further progress in this lecture easy. So I have a normal cell. There is a first mutation. Mutation may not recover, may be conveyed to a generation of cells. And then there may be a second mutation, then there can be third mutation. See, all these cells are looking different. See how the cells are looking different. So these all cells will be different. That's where the pleomorphism of cancer, the sizes of the cells, the shapes of the cells, the shapes of the nuclei, the sizes of the nuclei, the nucleolus, the cytoplasmic contours, everything becomes variable. And that's what is anaplasia. And the cells, they start resembling their embryonal cell type. Because which cells had the maximum potential to proliferate? The embryonal cells. For example, if you look at the stratified squamous epithelium, only the basal layer, the stratum basale, which is usually 1 cell thick or rarely 2 cell thick, that has the regenerative potential. So if all the cells become like that, primitive, they will start proliferating very fast. So that's what is anaplasia. Another thing. See, the cancer progresses in stages. This has been particularly demonstrated in the epithelial tumors. So we have a normal tissue. Then there's a hyperplasia if you go on irritating a normal tissue due to inflammation. Inflammation is becoming progressive and chronic. Then that may produce dysplasia. Then this may produce a severe dysplasia or carcinoma in situ. And finally, it may produce a cancer. And it may erode the basement membrane and may become invasive carcinoma. And then it may further invade the underlying connective tissues, become a full-fledged invasive carcinoma. Then it may start invading the blood vessels, the lymphatics, enter them. So it may invade the nerves. It may produce signs of paralysis or, neuronal deficit and neurologic deficit. So those things are going to happen. And, once it has exhausted the local area, it tries to go further on and on through the blood vessels, through the lymphatics, because that is the connecting system between the whole body. So it goes into different sites which are distantly located. And the key in cancer survival is metastasis. So weapon of cancer is metastasis. And the first weapon was invasion, the second is metastasis. So if we can control metastasis, we can control cancer. So if you look at the diagnosis of cancer, there are certain criteria. There are general criteria, general cell criteria. So cellular criteria. Then there are nuclear criteria. Nuclear criteria is a major criteria, I would say. So general and nuclear criteria are the main criteria. Some role for cytoplasmic criteria, very little role for structural criteria as a tool for diagnosis, as an approach for diagnosis. So if you look at the general and the cytoplasmic criteria in cancer and nuclear criteria of cancer, so we have anisocytosis. We have unequal cells. I told you, first mutation, second mutation, third, fourth, fifth. So that will produce a different lineage of cells, subclones, and all subclones will be different. And it's a faster division. So chromatin distribution may be unequal. So you will produce big and small cells. So we call it as cellular pleomorphism. The first thing is the cytology of the cancer is always overcrowded with one type of cells. Why? Because, we have a mass which is produced by one type of cells. When you are poking in there, you are retrieving that kind of cells much more than normal. For example, in a normal liver, if you poke a needle, you will get only 4 or 5 hepatocytes here and there. But in a hepatocellular carcinoma, just the last weekend, this weekend, Friday, we had a hepatocellular carcinoma. So hepatocellular carcinoma, you will get so many clusters of cells. Similarly, if you have a normal hepatoid gland and a hepatoid gland adenocarcinoma, in adenocarcinoma, there will be too many clusters of cells. So overcrowding, anisocytosis, pleomorphism, hypercellularity, this I have already told you. Then in the cancer cells, the nucleus is too big. Why? This is the nucleus. So nucleus becomes bigger in relation to the cytoplasm. We call it as narrowing of nuclear cytoplasmic ratio. Okay. So why that happens? Because nucleus is the hallmark of division. These cells are dividing fast. So they have very prominent euchromatin. They have very prominent nucleus. Cytoplasm does not get time to develop. It is weaker. It is lesser. That's the key. The cytoplasm may also be bluish. The chromatin is also coarse. White is appearing coarse. White is appearing stippled. White is appearing ropey. Why? Because there are light and dark areas. For example, here, you can see light areas and the dark areas. They are alternating. That's why. Then we call it as coarse chromatin. Already nuclear cytoplasmic ratio I have talked about. You may also get multinucleated giant cell formation. Particularly, a key to differentiate between a benign connective tissue or mesenchymal tumor and a malignant mesenchymal tumor is looking at the giant cells. Giant cells can be produced in any tumor, but more so in the mesenchymal origin tumors. That's a criteria. Then there can be nuclear molding. Means the membrane of the nucleus is weak. That's why it just twists, or torsion of the nucleus is there. I have already talked about chromatin patterns a little bit. It's a big topic. Then you also get mitosis. Normally, even in a highly proliferative tissue like that of the epithelia, or let us say hematopoietic tissue, you find very few mitosis. Why? Because the M phase, the mitosis phase, is just a few hours out of the cell cycle. If you look at the cell cycle, length, for example, length is about 24 hours. Then the prophase, metaphase, anaphase, telophase, cytokinesis may be just for 4 or 5 hours, depending upon. It may be 1 to 3 or 1 to 6 hours. That's an average. Okay, somewhere range. So something which is happening for a transient time, you cannot see it every time. It's like, Amitabh Bachchan will come to your city for 1 day, and those who have seen, they say Amitabh Bachchan has come. And those who have not seen, they say, I don't know. So that's why the mitosis is visible only during the metaphase to cytokinesis or the karyokinesis mainly. And that's where we count them. And this is a very important criteria of differentiating between the benign and malignant and even grading of the tumors. Let's get back into a little bit of the nucleolus. So nucleolus is a RNA-rich region within the nucleus. So it is lightly stained than the nucleus. See, that's nucleolus. So if the nucleoli are big, most of the mature cells don't show nucleoli. They are not visible, apart from some cells like neurons, the hepatocytes, or the lower basal layers of the skin, or hematopoietic cells. The nucleoli are not seen. So if the nucleoli are visible in many of the cells and they are too big, and if there is not just one nucleolus, there are multiple nucleoli, that makes it cancer. So that's a very important issue. We call it as anisonucleolosis or nucleolar pleomorphism. Similarly, whatever the size or shape of the nucleus, the nucleolus normally in a normal cell, you've seen that in neuron or hepatocyte, it's rounded, but it may become angular, any shape. Okay. So all those criteria have to be followed. Okay. One by one, and you have to make a summary of these criteria. And we have the main criteria as N-isonucleosis, N-isonucleosis, the cellular and nuclear pleomorphism, and mitosis. So all those have to be looked into while differentiating between the benign and malignant and grading of the malignant tumors. Coming back a little bit to the cytoplasmic criteria of malignancy. Normal cells don't have that blue cytoplasm, particularly the fully mature cells or the differentiated cells. Let's look at a squamous cell carcinoma. In a squamous cell carcinoma, in the mature cells, the cytoplasm is rather eosinophilic. But supposing that becomes basophilic, why basophilic? Basophilic means that there is more RNA in the cytoplasm. That means there is a more production activity going on. This is required because you have to divide from 1 to 2. You have to produce cytoplasm, not only the chromosomes. Vacuolization, abnormal vacuolization. These cells which don't have vacuoles, for example, in squamous cell carcinoma, you find. For example, in lymphoma, sometimes you find vacuoles. The cells which have vacuoles, they disappear vacuoles. The cells which don't have vacuole, they produce vacuoles. So abnormal vacuolization. Ill-defined margins. Normally, the cells have well-defined margins. In epithelial cells, it's difficult to see the margins. But in single cells, these margins are quite clear. So for example, in a lymphoma, the lymphocytes may have irregular margins. For example, in any other cancer, whatever you see, the margins are very regular or wavery. That indicates the cancer. Keratinization, abnormal keratinization. Normally, only the stratified squamous epithelium in most parts of the body, not in all, produces a keratinized layer. But that keratinization is excessive in case of squamous cell carcinoma. Sometimes the cells which are not producing keratin, for example, hepatoid gland adenoma, that starts producing keratin. So it becomes abnormal keratinization. I know several examples where they have shown this picture or slide to a human pathologist and he will say squamous cell carcinoma. We know it's hepatoid gland adenoma. Then a little bit about structural criteria of malignancy. See, epithelial cells, they have tight junctions. They are adhered to each other. They are adhered to the basement membranes. They are adhered laterally. So they will come in clusters. Maybe they are glandular, maybe they are the superficial epithelia. So glandular and epithelial tumors will show cohesive clusters of cells. There are non-cohesive clusters of cells, means there are sheets of cells in round cell tumors. There can be formation of acini or something like tubular structures, which may be seen in glandular tumors. Similarly, secretory material is seen in many glandular tumors in the background, or in some of the mesenchymal tumors, it may be quite prominent. One of the key differences when you look for histiocytoma and a simple macrophage infiltration is the background material. In histiocytoma, there is a background material. or secretory material. I have already talked about this. I don't think I need to discuss this. Only thing I want to say here is mitosis. So mitosis can be normal, can be abnormal. So generally in cancers, the abnormal mitosis may be seen, particularly in mesenchymal cancers, and more so in histiocytic sarcomas or histiocytic malignancies. You find so much aberrant mitosis. So there may be 3 poles. Instead of 2 poles, there may be 4 poles. There may be lagging of the chromosomes. There may be interlinking of the chromosomes. There can be unequal distribution of chromosomes, all those features. So here you can see a classical example of a rhabdomyosarcoma where you can see a giant cell. And how abnormal and irregular. There is hardly any normal muscle. You can just see the ghosts of the muscle. The rest of them are so big and small, so much overcrowding. Do you have so many nuclei? No, you have very few peripherally placed nuclei in the skeletal muscle. Here, what happens? You can see. So it's looking very odd. So cancer is looking dirty from the cell angle, from the appearance angle. So another example. This is leiomyosarcoma. So this is abnormal mitosis, 3 poles. And you can see how irregular the cells are. Some have big nuclei, some have irregular nuclei, some have relatively much smaller nuclei, some have elongated nuclei, some have more roundish nuclei, no shapes defined. So if you look ugly, you may be cancer. So the cancer, probably if the cells look bad, if they look ugly, they behave in an ugly way too. And in this, the clinico-morphological communication is very important. See, during my life career until now, I get more calls from the clinicians. I have a better relationship with the clinicians than with the pathologists because they may be jealous. And clinicians, they call me every day, at least 10, 15 calls I have between ourselves just to reach at a proper diagnosis. And that's the key. So unless you get the everything in terms of signalment, history, clinical interventions, clinical signs, size of the tumor, appearance of the tumor. Sometimes I have to call up for the photograph of the tumor. Still, I have last Friday's 2 photos on my mobile. Okay. And that's very difficult also. Sometimes people don't want to part with their photos. They don't want to give me photos. So I have to approach through students. So if you look at the visual analog scales of different range of things that are going to happen. So this is a normal cervical epithelium. See, it is little bit changing. Then it is becoming more dysplastic. And finally, it may become a carcinoma. So cytology also changes. See, what is the nucleus size? See, what is the nucleus size? See, what is the nucleus size? See, it's so much clumping. So that's how the cytology is going to change. And sometimes it becomes very, very difficult to say whether this is normal or abnormal because till dysplasia, it is borderline. But once it becomes carcinoma in situ, it becomes a cancer. And once it becomes invasive, it becomes further more detrimental. So I didn't put the pictures, actually. I had done slides which showed all these features. Anyhow, I'm showing you some cytology. So you can see this is hyperplasia. The nuclei are big, the cytoplasm, instead of red, is becoming blue. Okay. This is stratified squamous epithelium. Now this is another step. Look at this. The nuclear to cytoplasmic ratio, the nuclei become aberrant. So this is atypical. This is hyperplasia. This is atypical hyperplasia. And now it becomes a dysplasia. Look at that. Some cells are big, some cells are angular, others are roundish. They have big nuclei, they have coarse chromatin, they have blue cytoplasm. And now, this is squamous cell carcinoma. How the things are changing on cytology. This has to be done with a lot of, you have to have experience. It cannot be done overnight. So now I come to some of the important tumors in the canine. I cannot talk about everything. Actually, I can talk about TVT. I can talk about lymphoma. I can have full lectures on those mast cell tumor or any other tumors, We can talk squamous cell carcinoma. One more lecture, full lectures can be there on each of them. So here, let's start from the epithelial tumors, because 70% of the tumors are epithelial. So here, this is oral papilloma, which is pretty common, very dirty to look, very, dry appearance. And once you do cytology, you will get this. So in cytology, what you will get clumps of superficial to intermediate cells with a lot of keratin, because this is the papilloma. So you can see how it is proliferating. It is growing towards the airway, towards the area of least resistance. And there is a lot of keratinization. There is a lot of proliferation. If you have cytology, you will find this. There is also sometimes the squamous cell carcinoma is produced from the papilloma. So over time, if it continues, particularly in humans, if you look at the cervical cancer, okay, it is produced by the papilloma viruses. So papilloma viruses, they produce first warts, and then they may produce cancers. This is pretty common. That is why vaccination against the human papilloma virus can reduce the incidence of cervical cancer. Then coming back to the squamous cell carcinoma, this is in the subungual region here. And you can see anisokaryosis. This is the typical cytology. There is a different type of maturation. There is a irregular maturation of cells or asynchronous maturation of cells. Some cells will be small, but they have yet big nuclei. Sometimes you find like this. Sometimes you find tadpole-like cells, which are characteristic in human squamous cell carcinoma. If you look at the histology of this, look at the histology. So there is a lot of keratin. It is an inverted papilloma-like thing. Normally, keratin should be on the outside, but this is inside. And this is an abnormal keratinization. See, it's not maturing in an orderly fashion from the stratum basale. stratum basale or germinativum, we have spinosum, then we have stratum lucidum, then we have stratum granulosum, then we have stratum corneum. So they are maturing in a very rhythmic fashion. This is arrhythmic. So some cells will be big and small, and finally they form irregular keratin. That's what is the key of a squamous cell carcinoma. And same thing on cytology, but sometimes there are borderline cases, particularly in the nasal cavity. In cytology, I see that quite often. Maybe I have a pic of that. Now, there can also be basosquamous tumors. Any dog which is more than 8-9 years old and has a mass on the neck particularly, or head and neck region, it may be a basal cell tumor or basosquamous tumor, cancer, carcinoma. Basosquamous means it has both the patterns. So you have the basal pattern, you have the squamous pattern. This is the basal pattern. So basal cell tumor generally arises from the basal layers of the skin. It has interlacing ribbon-like arrangement with uniform sized nuclei, whereas in squamous cell, there are irregular nuclei. They are big and small, lot of pleomorphism. This is hepatoid gland adenoma. Hepatoid gland is seen in both male and female, but the tumor is seen only in the older dogs. So this is a perianal gland, which usually gets enlarged with age. See, all these reproductive tissues, they undergo changes with aging. So maybe it is a mammary gland, maybe it is a uterus, maybe it is an ovary, maybe it is a hepatoid gland. So all those things, they go on changing with age, with the hormonal patterns. So this is also another hormone dependent gland. Similarly, we have another anal ring sac tumor. So hepatoid gland adenoma, liver-like cells, they are clusters of cells, little bit big nuclei, more gland than the normal, appears like a mass. But supposing it is a dog of more than 10 years, it may be more, or ulcerated, it is more likely to be a hepatoid gland adenocarcinoma. So general owners, they go on ignoring when it is a small mass. They let it go, once they find it is too big and ulcerated, dirty to look, bleedy, then they come to the clinic and it is turning out to be a hepatoid gland adenocarcinoma. This gland is not only present around the anus, but is also present at the base of the tail and in the neck also. But the major tumors that you see are in the anus, to a certain extent in the tail, rarely in the neck. Now this is hepatoid gland adenocarcinoma. So see how the cells are changing. They become so big nuclei. The cytoplasm becomes basophilic. And this is how the picture is changing on histology also. Can you see how the overcrowding big nuclei are there? This is another adenocarcinoma. This is adenocarcinoma. And can you see the clusters of cells forming the glandular patterns? Lipoma is another connective. So after epithelial tumor, let's talk a little bit about, in fact, I should have talked about round cell tumors, but anyhow, in this presentation, so C lipomas are soft masses, painless, generally in older dogs, more so on the abdominal region. And they are cooler to touch than rest of the body. If you touch the surrounding area, that will be little warm than lipoma. So when you do an FNAC, you will get either fat droplets or adipocytes. See, adipocytes have well-defined membranes. Here, there are no membranes. And this is the picture. And many a times, these lipomas are infiltrative. They are infiltrating into the adjacent connective tissue or the musculature. So even after removal, they reoccur. This is adenocarcinoma. Oh, sorry, liposarcoma. So see, this is lipoma. Where is the nucleus here? It's just on the periphery, very small. Look at the nucleus, hardly visible. But here, the nuclei become so prominent. And there, on cytology, they become even much more prominent. And mitosis is there. Just instead of single big, here, single big locule of fat, there are irregular vacuoles of fat. Irregular vacuoles of fat, multiple in the cell. That's the key. You may find giant cells. So now we come to the round cell tumors. We can have several round, actually 5 types of round cell tumors are there, out of which the histiocytoma hardly has been studied, and very few reports of histiocytic malignancies are there. Now we are encountering every week one malignancy, histiocytic malignancy, because we started seeing it. Lack of knowledge also, or ignorance also, reduces the incidence. Why more cancers are now reported in India in humans and animals? Simple answer is awareness. Aging. Cancer is a characteristic of age. So any human above age of 50 or 60, similarly, any dog above the age of 10 may have cancer incidence up to 50%. So this is reported. This is a postmortem data. They may have overt malignancies or covert malignancies, means which are just detected at postmortem or on histopathology. The incidence is 50%. So there can be genital TVT, which is very common. It can be in a female or it can be on a male. And you can see the cytology, the classical cells on HE. HE you can do, I told you. This is in the lymph node. In the lymph node, it becomes very aggressive. You see there are so many mitoses. 1, 2, 3, 4 mitosis. If you do vincristine, you can follow the treatment through cytology, see how the cells have become shrunken and apoptotic. And this is the histopathology. You find the round cell sheets intermingled with the fine fibrovascular stroma, and it's just below the skin. That's a beautiful picture of TVT. As per cytology, the TVT has been classified into three subtypes: lymphocytoid type, plasmacytoid type, and the mixed type. So if you have overpresence of lymphocytoid cells, round cells, for example, here it is lymphocytoid. If you have more of plasma cells, then it is a plasmacytoid. So generally cutoff is 50 to 60%. So when you have more than 50% plasmacytoid, then you call it as plasmacytoid. The prognosis of plasmacytoid is worse than the lymphocytoid, even worse than the mixed type. So plasmacytoid type TBT carries a worse prognosis than the other subtypes. And also, the genital TVT has slightly bigger cells than the extragenital TVT on morphometry. And another thing, when you have TVT on the genitalia, it is a fragile mass. Whereas in rest of the body, if it is extragenital, it is harder mass. For example, here, this is extragenital TVT. See, it's all over the body. And after vincristine, it will regress. It's better. This is mast cell tumor, a very common presentation that you see. Whenever you see any retriever dog, golden retriever, or black labra, or black labra retriever, it is above the middle age. Any mass on the limbs or on the abdomen, it's likely to be mast cell tumor. Interesting thing about mast cell tumor is that it is reddish, hairless mass. And there may be episodes of increase and decrease in the mass. When there is a histamine buildup release, then it becomes swollen due to edema, due to inflammation. Otherwise, it shrinks. ज्वार भाटे की तरह. So, it's very simple diagnosis, I tell you. This is one of the simplest ever diagnosis. So you can see mast cells character on any Romanowski stain. And you can do Tolidin blue to confirm. Here the blue is nucleus and purple is here. The purple are granules and nucleus is light colored. We call it as negative staining. And mast cell tumors, they invoke a eosinophilic response over time. And eosinophils, they, whenever there is a connective tissue damage through release of these cytokines or histamines and all, so what will happen? The connective tissue undergoes, the vascular walls, they undergo necrosis, degeneration. And differentiating between a benign and malignant mast cell tumor would be based upon the nuclear pleomorphism, the cellular granularity, hypogranularity, the granular pleomorphism, the presence of binucleated cells, the presence of multinucleated cells. So grading can be very well done on cytology of mast cell tumor. Another very important aspect of, actually I can have one lecture on mast cell tumors. So another very important issue about mast cell tumor is that its location. I told you it's generally on the abdomen or limb region. If it is just a solitary small mass, if it is a big mass, if it is a recurrent mass, if there are multiple masses, whether it is movable under the skin or immobile mass, whether it is an abnormal location oral cavity. Other day, we saw it on the tongue. If it is in the subungual region, if it is in the eye, it is more likely to be malignant. Lymphoma is another thing that we see, another round cell tumor. So most of the lymphomas are multicentric. In dogs, they are primarily B cell lymphomas. But supposing they are affecting the lymphoid tissue, the lymph nodes, or the spleen, they are likely to be B cell. But supposing they are inside the organ, for example, GIT lymphoma or respiratory lymphoma, they are likely to be T cell. In cats, their classification is different and difficult. In cattle and buffalo, lymphomas are there. Actually, every species of the lymphoma are there. In some species, they are induced by the retroviruses. For example, in cats, in the murine species, in the bovine cows. Interestingly, in buffalo, lymphomas are there and they are not having any relationship with the BLV. This is our study now. It's very interesting. So we call them enzootic bovine leukosis and sporadic bovine leukosis. So sporadic leukosis is more common in buffaloes, and zootic is more common in cows. So this is a melanoma. That's another tumor. I'm, not taking up the plasma or the histiocytic because those are quite complex, the histiocytic tumors. It requires a lot of discussion. Time, I told you, I'm already having little difficulty. So, so this was a dog from Chandigarh. There were several masses which were hidden under the hair coat. Okay, and we just palpated them and took up, and we found so many this melanin-laden cells. And see, they are pleomorphic. And there is a lot of secondary suppurative inflammation. Remember, the inflammatory cells are much smaller than the tumor cells. That's the key. Sometimes tumor cells may be 10 times, 20 times bigger than the inflammatory cells. This works both in histology and cytology. So that was malignant melanoma, and that was multiple sites. It was long drawn case. But what about amelanotic melanoma is very difficult. If it is amelanotic melanoma, then the cytology is very difficult because it may be epithelial-like, it may be mesenchymal-like, it may be round cell-like, all three types. We started doing this ultrasound-guided FNAB, fine needle aspiration cytology or biopsy, particularly on the peritoneal fluid, the liver cytology, the internal lymph node cytology, some GIT wall cytology, some kidney cytology, some splenic cytology, prostate cytology. I was involved in so many theses, I did, if you look at my, publications, most of them come from the students of the clinical disciplines rather than pathology discipline. Because I have guided so many, I have written 200, I may have guided much more than that. I have underquoted certain things. 20, not 28 lectures in the last 3 years. I have given at least 50 lectures in the last 3 years at different fora, particularly in the COVID. I started with just one lecture, and there was a series of lectures. Every 15 days, there was a lecture. So this is prostate. So this is a work on PhD of a surgery student. And you can say this is prostate adenoma. And now this is adenocarcinoma. That's the difference. So look at this picture. The cytoplasm is plenty. There are glandular vacuoles or secretory vacuoles. And here, the nucleus is much bigger. The cytoplasm is going basophilic. The nuclei are irregular. The nucleoli are prominent. So it becomes a carcinoma. Another adenocarcinoma in abdominal mass. Look at the nucleoli. Then I had a passion for this canine memory tumor. We did 5-6 theses on this, 4 or 5 theses in pathology, and maybe 2-3 theses in the surgery department, 1 in the medicine. So a lot of publications emanating from there. Maybe more than 10-12 publications. And some of them in good journals too. And one of my simple article, which was published as a review article, has now more than 60-70 citations. Mammary gland tumor as a model for human breast cancer. So this is the human tumor, this is the animal tumor. You can't see much difference. Look at grossly, they are quite similar. And here, this is the cytology of the adenocarcinoma, and that's a higher magnification. When you see clusters with big nuclei overriding of nuclei, coarse chromatin, that's adenocarcinoma. Now in the mixed mammary tumor, apart from that, you may get ground substance, you may get mesenchymal cells, so it may be a mixed mammary tumor. So interesting thing about the mammary tumors is that they have such a diverse variety. It's a whole range of tumors placed under the category of mammary gland tumor. Nowhere in human oncology that kind of model is available. So you have carcinoma, simple carcinoma, complex carcinoma, carcinosarcoma, sarcoma, and many more diverse type of tumors. Now this is into the lymph node. So supramammary lymph node may be involved, or inguinal pair is involved, then inguinal lymph node may be involved. If the front pairs are involved, then the axillary lymph node may be involved. So you can see this cluster of cells, what it has to do with the mature lymphoid cells. So this is the metastasis in the lymph node through cytology. Another question is, can immunocytochemistry replace immunohistochemistry? This is our own work. So here you can see the ER beta receptors, they are nuclear receptors. Similarly, progesterone receptors, they are nuclear receptors. HER2 is a surface receptor. So you can see, actually it is ER receptor, it is EGFR, epidermal growth factor receptor, which is known as HER2 here. And then we have the cytokeratins or vimentin. So all these expressions can be seen in cytologic samples. But the problem with cytology is that you have a lot of fluid and blood contamination, pus contamination, which makes it worse while doing the immunocytochemistry. The retrieval of the antigens is much more tough. You have to use all your techniques available and modify them and find the proper fields. Interpretation is also very tough. So what people now opted for is, if you have abundant cells in the cytologic retrieval, lot of cells in the fluid or a lot of cells in the syringe, then you can make the cell blocks. You can embed them into the paraffin. You can make a clot by using the thrombin and then embed them into the block and cut section. So this is, they reassemble. Interesting thing is the cells, they reassemble into midway. This is the typical histopathology. This is not typical histo, but somewhere between this. So that's bridging the gap, but this is not possible in every sample. It's possible only if you have plenty of cells and plenty of material with you. If you have just one slide material, what histopathology or what slide, what block making will you do? You will be able to make only just one slide. You need to have enough material. That's another cell block which is finally reassembled. This is histology, this is histology. Then peritoneal fluid is another issue. Actually, I could have talked about so many cytology, but there's time and I have that problem. So if the peritoneal fluid is there and it has very few inflammatory cells and cell clusters, rather cell clusters, think about some primary or metastatic tumor. And if it is a lot of hemorrhage, hemoperitoneum, that also warrants examination thoroughly. So this is adenocarcinoma, primary or metastatic in the peritoneal fluid. One of the key tumors that you get is hemangiosarcoma. Hemangiosarcomas are so often seen in the peritoneal fluid in our setting. So you can see the nuclei are very irregular. The nucleoli are prominent. The cytoplasm is vacuolated. Cells are so pleomorphic. I told you the sarcomas are much more pleomorphic. Hematology has some value in cancers. For example, in detecting some primary tumors of the bone marrow or metastatic tumors in the bone marrow when they revert back into the blood. For example, this is a lymphoma or lymphoid leukemia. This is a lymphoid leukemia more because you see very abnormal type of lymphoid cells. See, this is an immature or irregular, or this is very molding of the nuclei. And can you see the different shapes? Then we go over to the diagnostic pitfalls in cytology. I have a word of caution here that when you are doing cytology, you must be particular at each and every step. It matters. A simple thing matters a lot. So your collection, your choice of material, choice of site, and mention always everything on the slide. For example, they say cytology. What is cytology? Nothing. I don't know which cytology. So you should mention right, left, which part of the hind limb, how big the mass was, whether it was ulcerated, whether it was fast growing, what is the feedback from the owner, whether it's a male or female, whether it's a dog or cat. You have to mention everything. That makes the job easy. Otherwise, it's very complex. So poor collection can be a problem. So if you don't make the slides properly, don't collect the material properly, supposing you go on poking in the skin more than poking into the tumor or mass, you will get skin cells. So don't just rub this needle too much on the skin. You will get a lot of bacteria, squamous epithelial cells, keratin, and all that. Similarly, the proper containers and proper fixatives, if they are required, they should be there. So if the container is soiled, if it is already having a lot of bacteria, even touching your hand or finger on the slide may produce some squamous cells because your hand has squamous epithelial cells which are likely to slough off, and keratin fragments and bacteria. Poor fixation. So sometimes the materials are collected, they are not collected and fixed in a proper way. So wherever you need or you delay the things. So cytology is a very quick process, I told you. If you put too much pressure while making the squash, many times what happens, the smears are already dry and then you put another slide or you make a spray. The glove powder can be looking like cells. Similarly, the ultrasound gel may be a contaminant. Another problem is inflammatory changes, particularly the reactive changes in the histiocytes, in the fibroblasts, in the epithelial cells, hemorrhage, infarction, necrosis. They complicate cytology. Artifacts I have already discussed them. That's why cytology is a continuous communication between the clinician and the pathologist. Some reactive changes, for example, here there is a fibroplasia. See, they are running nicely in one direction and there are big cells, big nuclei and smaller elongated nuclei. So this is more of a reactive hyperplasia. This is a reactive hyperplasia in the respiratory epithelium of the nasal cavity. See, little bit atypical it is becoming. This is a reactive hyperplasia in the urinary bladder. When there are stones, when there is a chronic cystitis, the bladder will show this kind of appearance. But this is a transitional cell carcinoma. So it needs experience. See, these three guys, the second opinion is always must. See, these three guys will never agree. One will say this, or this will say this will they say this. Because it's a difficult case, whether it's a dysplasia or it is a carcinoma, early carcinoma. It's a difficult question there, somewhere here or somewhere here. So it has been seen, if there are three pathologists, this is reported. So if you seek opinions from three pathologists on the same difficult slides, the variation can be up to 30 to 40%. So this much variation is possible. It's a subjective evaluation. That is why the presence of a pathologist, cytopathologist at the time of obtaining material, especially in the fine needle aspiration. What happens in, when you want to take a cytology sample from a lymph node, what will happen? You will tell the other person to hold the lymph node and you will poke the needle. So you don't know whether that lymph node is left free or has slipped from the hand. So what you get, blood and fat, no lymph node. So that is why a pathologist must be there who can guide you where you should do. I remember one case on the surgery table, and one of the very big surgeons from US was there in our surgery department. So first, our own surgeon took the sample, there was only blood. And then he took the sample then there was a pulmonary carcinoma. So you have to go to the proper site. The lesion may not be symmetrical, may not be distributed all over the organ. It may be just focal. So you have to penetrate that area. Supposing you penetrate central necrotic part of the lesion, which happens in most of the solid tumors. So what will happen? You will get the necrosis. Supposing you get so much pus secondary inflammation. That's why you need to see the lesion, need to evolve the process according to the situation. Supposing there is a ulcerated, bleedy, pus-filled lesion on the surface. So one slide you make like this, another after cleaning thoroughly, because underlying there may be cancer, histiocytic cancer. This slide I have shown several times, and it is my preferred slide. Actually, I took it from the peritoneal fluid. I call it as a smiley cell. And you can see the radiating corona binucleated cell, and the cells are finally smiling, and you should also keep on smiling. I pray to the God there a long life and pleasant time ahead for everyone. Thank you very much. And I once again thank the key resource persons, particularly the Dean of the College, Dr. Chandras, and Dr. Kumar, Narendra Kumar, Dr. Purnima, Dr. Sanjeev, and all my friends who are there. I may not be able to name them. I wish you all good luck. Thank you very much. Thank you. I think you heard me all. Thank you.
Thank you, sir. The lecture, you can stop the screen sharing, sir.
Okay, okay.
Thank you so much, sir. The lecture was so interesting and so intricate, and I hope all the participants are enriched with the knowledge of cytology now.
Not actually, it is a long-term process. If I come there, I will be taking the whole 2 days, okay, on cytology itself, or maybe a longer time.
Yes, sir. We
Then,
will be
then you
definitely
will become.
join you again and again, sir. And thank you for your lecture. If the participants having any query, please they can ask in the chat box.
Yeah, if there are any questions, you can ask me. If there are.
Any questions, please? So one question we have from
Yeah.
Thakur. Wait.
Uh-huh.
Why there is so much cytoplasmic vacuolation in TVT?
This is abnormal vacuolization, okay. The origin of the TVT is believed to be histiocytic. Okay. The histiocytic sites do have vacuoles, as you know. But this is more punctate vacuoles than the histiocytes. Histiocytes have rather irregular vacuoles because of the lysosomes in them. Okay. But here, these vacuoles, they are, you can say, phagocytic vacuoles. Okay. But here, these vacuoles are abnormal vacuoles because these cells are not having phagocytic potential. They are more, I told you, the cells which don't have vacuoles, they produce vacuoles. And they produce irregular vacuoles. Let's talk about a classical example of, you see, this liposarcoma. So in liposarcoma, normally there is a one big vacuole, or we call it as locule of fat. when in a normal adipose tissue, adipocyte. But once it becomes liposarcoma, you find so many punctate vacuoles. I showed you that pic. Okay. Same way, when you look at lymphoma, there is no vacuole in lymphoma, but in normal lymphocyte, but in a lymphoma, there are vacuoles. Similarly, when you see the squamous epithelial cells, there are no vacuoles, except for degenerating cells. But once we have squamous cell carcinoma, there are quite often the vacuoles. Okay. So vacuoles, and we see in hepatocellular carcinoma. See, normally in hepatocytes, there are vacuoles which are lipid laden or which are fatty change, we call it. Okay. They are very regular vacuoles. But in hepatocellular carcinoma, those vacuoles become totally irregular. They are not so smooth. I hope I was able to resolve your query.
Thank you, sir. One more question is there from Dr. Abhijit. Sir, can you put a little more light on how to differentiate between lymphoid hyperplasia and lymphoma?
That's my favorite topic, and it takes a long time. Okay. Yeah, simple formula would be to look at the number of monomorphic cell of population. Okay. So anything which exceeds more than 50%, supposing you have large lymphocytes more than, normally in normal lymph node, there is a heterogeneous population of cells. Okay. So it's like this. It's like, can you see my head? It's like this. So you have the small lymphocytes on top, then you have the medium, then you have the large, then you have the plasma cells tapering. But supposing, and that small lymphocytes are usually about 70 or even more, 80%. So if the small lymphocytes become 30% and the large lymphocytes becomes like this. Okay. So that's lymphoma. I hope one type of lineage, tumors are just originating from one cell lineage. We call it as monoclonal origin of tumors. Okay. Or single cell origin is the key process. That's why we need a flow cytometry. So on flow cytometry, we see how many cells are of one lineage in complex cases, in humans. I hope I was
Thank you, sir.
able.
One more question from Monica.
Yeah.
Sir, please
Yeah.
also share your knowledge about mast cell leukemia.
See, mast cells are very few in the bone marrow. Their percentage is just a fraction of percent. But they can originate, leukemia can originate from the mast cells of the bone marrow. Okay. But at the same time, when you have a mast cell tumor, it may go into the bone marrow, metastasize in the final stages, and then may revert back into the blood. Okay, that's another part of the story. We have seen one or two cases like that. Same way, differentiating between lymphoma and leukemia. Lymphoma starts in the lymph nodes, lymphoid tissue, then finally goes into the bone marrow. Whereas lymphoid leukemia will start in the bone marrow, then will go into the lymphoid tissues. So what is primary? What is secondary? That's very, very important.
There's one more, sir. What about the recurrence chances in mammary gland carcinomas?
Mammary gland carcinomas generally reoccur because it's very difficult to get rid of whole tumor. we don't follow a proper course, okay? For every tumor, you need to determine the margins, and you must cut off the adjacent lymph nodes, as well as you should go, let us say, this many centimeter away from the primary tumor, whatever is visible to the naked eye. We are doing surgery with the naked eye. So tumor are already here and there into the vicinity. And there are, 5 pairs of mammary glands. Okay. So already in one mammary gland tumor maybe, and through it has spread into the another one. You are cutting off that. So whole chain of the mammary gland has to be removed. So recurrence is quite frequent. And another thing, if it is a sarcoma, it's more difficult to get rid of. Sometimes as small as tumor when you try to grade the tumor or stage the tumor, grade and stage, two different things. Stage the tumor. The size of the tumor is first thing that you have to take into consideration. So generally a tumor less than 5 centimeter
ENM,
is
sir.
believed to be a benign tumor. Okay. But in sarcoma, it does not hold true. A 2 centimeter tumor may be already metastatic. So already if the metastasis has occurred into different organs, what you will do? Tell me.
And sir, what if we remove all the mammary glands? Then still there will be chances to recur. I mean, what is the chances of elimination of the cancer at that time?
Never know, surgery is just a naked eye thing, you're not looking with the microscope. C cells move away from the primary site. They go on moving away from, and which may not have connection with the original tumor even. Okay. And how many people in veterinary, they look for the margins? I don't see.
True, sir. We have one more question, sir. I think everyone is so interested. Actually, this is a very interesting topic. So we have one more question. So what is the maximum time period we can keep a cytology slide without fixing before staining?
Maximum period, I don't know. It can be a very pretty long time, I would say. In terms of, how you keep it, that is very important. See, first of all, it has to be air dried, wrapped in a clean piece of tissue paper, which is not contaminated. Then, wrap it in aluminum foil, store it in a cool, dry place, which is free from moisture. You can keep it quite long. And that's the way how the people send the slides to different destinations. In US, IDEX has a different center for cytology. So people from different parts, they send samples to that center. And most of the slides, they make, centers of excellence. Here we'll do the PCR. Here we'll do the cytology. So I think you can keep for a longer period. Okay. And I can't say, ये तो वही बात है ना कि गाड़ी के सभी सिग्नल हो चुके हैं, गाड़ी थे थोड़ी देर तो 1 सेकंड भी हो सकता है, 2 सेकंड भी हो सकता है, 2 घंटे भी हो सकते हैं, 2 दिन भी हो सकते हैं, 2 महीने भी हो सकते हैं। सालों को देखोगे, सेंचुरी को देखोगे तो 2 महीने कुछ नहीं है, ठीक है। अगर एक एक पूरे दिन के सेकंड निकालोगे, उसमें से 2 से 10 सेकंड शायद बहुत थोड़े होते हैं। तो हर चीज की मतलब I can't say that time frame, nowhere it is defined. I don't think it is ever defined.
So best यही होगा कि जितनी जल्दी हो सके हम we can send it for the lab.
No, you can keep it. It's not necessary. Immediate sending is not required. Once it is dry, wrapped, packed, okay. But you can refrigerate also. But the problem is moisture may go in. Once moisture is there, then there can be fungus, bacteria.
Okay, okay.
Send it without fixation. Don't fix it ever.
Yeah. Thank you for the knowledge, sir. One more question. Sir, could you explain the cytological interpretation of the cytology image shown in your presentation, slide number 3 or 4? I think that
Let's see.
this will
This
it
is
be
a bit boring.
you
I
need to
think I
share
have
it
to.
again, or
Anyhow, I
there
can check.
might be
No,
difficulty.
I will not share. I will just check on my monitor.
Okay, okay. If this is possible, sir.
Yeah.
3 or 4?
Which slide did you say?
3 or 4, sir. Third or fourth slide. Dr. Arathi, which
Okay, third.
exactly, which one you wanted? Can you explain?
Third one. Third and fourth one. Okay. The third one is regarding, the basis of cytology and the effect of environment on disease production. Okay. Okay. I hope you got it. So the fundamental unit is cell. Cell is building, groups of cells, tissues, then tissues to organs, organs to different systems, and then finally the organism. That was there in the slide. Okay. And another was regarding the influence of environment. See, there is a myriad of agents which are in the environment. Still, the reactions of the body are limited, and that you can see through cells. Okay. That was and there was another one, third one. Third one is just simple. Third one was just about the architecture and non-architecture. On cytology, you get just the cells. See, every organ, the fundamental is have the parenchymatous cells and the stroma. Okay. The parenchymatous cells are cell specific, which are cohesively performing a particular committed function. So this can be just one type of cells. It can be different type of cells in one organ. For example, we have type 1 pneumocyte, we have type 2 pneumocyte. For example, we have bronchial epithelial cells. Okay. In that also, we have the epithelium and goblet cells. Okay. Similarly, in pancreas, we have exocrine, endocrine, liver, we have the hepatocytes and the bile ductular system. Okay. So that's parenchyma. What is holding that parenchyma together is the stroma. So you cannot survive of your own, you cannot hang yourself. So if you look at your body, it is composed of connective tissues. Okay. It is composed of bones. It is composed of ligaments. It is composed of tendons. It is composed of muscles. That is why joints. That's why you look like this. Otherwise, you will be a mass of, on the ground. So that's what architecture does. Architecture, the stroma builds up that structure of the organ, that alveoli, that bronchi, that bronchioles structure, the liver hepatic cords, the central system, the portal system. Okay. So when you just poke in, so you will get just one type of cells predominantly. Stroma hardly will come. That's where the complication in interpretation of cytology lies. I hope you were able to get that.
Yeah, thank you, sir. I would like to add one more. Sir, is there any possibility that one particular single slide have some areas of benign tumor, the similar lesion showing benign tumor, and the other part or some part is showing malignancy. Is there possibility of that?
Very much, very much.
And if it is
Always.
there, then what should be the mode of diagnosis?
You see, in cancer hierarchy, malignant is a grown-up individual. So once you are grown up in adulthood, you cannot be called a child. I hope you got the answer. So benign, you have to ignore that.
Okay.
Yeah.
Thank you, sir. I think we don't have any further questions. So thank you so much. It was such an really interesting lecture, sir, delivered by you. And now I would like to invite Dr. Narendra, sir, for our formal vote of thanks.
Yeah, I'm thankful to him too, for having been on the mail through mail. He has conversed with me, and I'm thankful to him. He's, I think, head of the department.
Yes, sir. Yes, sir.
Yeah, good.
He's there, sir. Please unmute yourself. Naren, sir. Hello. I think there's a network problem, sir. So I'll thank you, sir, in the behalf of Naren, sir. Thank you so much for joining us, and we'll also hope that you will join us again and again in person as well. And we will definitely got
I
to.
will be very happy to come to your place and deliver a few lectures, maybe for a week or so. I will be very, very happy, and I'm looking forward. But I have to choose the appropriate time. Okay.
It's okay, sir. Whatever
Sir,
time.
thank you, sir. Thank you, sir. I'm connected from beginning. And
Oh,
lecture was very
you
nice,
didn't
sir.
leave. I thought normally, deans will do their job and sleep. Okay. But
No,
you are
sir. I was
already on.
connected. And lecture was very nice, sir. And I'm also creating interest now in these things, sir.
It was so interesting, sir, really. And cancer is
Yeah.
something we all are like find so fascinating every time.
Sometimes it's not always the theory that works. One time, what happened, one person, this horse owner, he said that my horse is urinating dust, white dust. Okay. So he's urinating, urine is very thick, and it was summer. So it just, clots or becomes a whitish powder. So I said, you bring that powder. He brought that powder, and I dissolved it, okay, in water. And then we looked at, it was all, oxalate crystals, which is normally there. So
It's a no.
carbonate crystal. It was carbonate crystals. So, which is very normal, carbonate and bicarbonate. And you can discriminate between carbonate and bicarbonate. You can also discriminate between a triple phosphate and a simple phosphate. So this is how, the things work. Another person, it's interesting. So another physics man came to me. He said, I want to do something with the fat. Okay. And I want to combine something, they make molecules like that. Okay. Nanoparticles or something. Okay. So I said, I'll see under the microscope and let you know how you are doing the things. And he was very happy. Another lady came from this dairy technology. She had a different issue. She brought some, things, and I just another thing, one person, he had that this garment industry. He wanted to see, I want to see the fineness of my cloth, fineness of the cloth. So you see under the microscope, and you can tell which cloth is more fine than the other one. So the thing is that whatever you are doing, if you do that, you can invite people from different disciplines and you can impress them. And that is how I built, a network of people all around, I didn't have only pathology connection. I had connection with every discipline in the college. And look at my publications. They are from many, many diverse fields. They are not just
Yes,
one field.
yes.
Even fish pathology, I have a lot of good publications. They are in fish pathology or other important journals of fish. And similarly, I have very different type of things I have. So this is only when you look at the things seriously. So cytology is one thing. I tell बच्चों को बताता हूँ कि आपने लंग देखा उसमें लीजन लिया तो आप पहले स्मीयर एक और क्वेश्चन देने वाला हूँ वो अगर बच्चे कनेक्टेड हो वो क्वेश्चन ये है कि कभी भी साइटोलॉजी के सैंपल को फॉर्मलिन के साथ ना रखो फॉर्मलिन वेपर्स fix the cytology slides, samples, cells, and they become impermeable to stains. You cannot stain that slide. So that's one very important caution which I must give. Surgery में क्या होता है कि वो इधर हिस्टोपैथोलॉजी में उसी से पकड़ा फोर्सेप्स से हिस्टोपैथोलॉजी में उसी से वो स्मीयर बनाई जा रहे हैं क्या स्टेनिंग होगा ठीक है Thank you very much.
So then,
Dr. Chandras, I've taken extra time.
No, sir. No extra time. We have utilized our time today.
Sir, it is the liberty I can take with you only. You like people,
No, sir.
not with everyone.
You can still speak for hours. I know, sir. So we have got today something, and I'm glad for that, and thankful to you, sir.
The main thing is, Dr.
Deliberated
Chandras,
so
the main thing, Dr. Chandras, is to imbibe the people to do something. That's the main thing. That should be the main aim of the person. If you can imbibe interest, if you can, encourage them to do something new. So many people who have attended our this 21 days program, at least 2-3 of every 25, 20 people, they started doing cytology. That's the interesting part.
yes. So we'll hope that our college also will start
Yes.
very soon. And when you will come, you have to set up everything. Then we may also start.
No, I will definitely do it, Akshay. No problem. You are so close to
Yes.
me, and I will be very happy to do it.
Thank you, sir.
thank you, sir. We'll definitely work on this in the guidance of you, sir.
Okay. Thank you very much,
sir.
Doctor.
Thank you, Dean, sir. And thank you, every participants, for joining us. It was a hectic day, I know. For the knowledge, I think we can spare for it. It's worth it. So shall I end this meeting, sir?
Yeah, thank you, everyone. Thank you, and good evening. Thank you.
Shall I end this
Namaskar, sir.
meeting, sir? Okay. Sir, can I end this meeting?
Yes, please.
Thank you, everyone.
So, namaskar, sir.